All right, so we're going to be looking at diseases of the respiratory tract in chapter 19. The respiratory tract is the most common place for infectious agents to be able to access or get into the body. We breathe 24 hours a day, and anything we breathe in must come through the respiratory system and be there at least temporarily. The respiratory system is divided into two parts, the upper respiratory tract here, let's see if I get my pen going, and the lower respiratory tract. The upper respiratory tract contains the mouth, nose, nasal cavity, all these mucous membranes, sinuses, throat and pharynx, epiglottis, larynx. Lower respiratory tract is going to contain the trachea, which is the bronchi, bronchioles, and alveoli as well. All right. And so we can see all these structures here. We've also got our four pairs of sinuses. We've got the frontal sinus, okay, which you're probably familiar with here, all right? And then here's the sphenoidal sinus. You've got the maxillary one, which is right here. Okay, so you're probably not as familiar with these. And then you've got ethmoid right here as well, all right? And so those are kind of some important areas for sinuses there. All right, so what are the defenses of the respiratory tract? Well, many of the anatomical features protect us from infection. So, as I like to say in anatomy a lot, structure determines function. And I also like to say, flip that around, function is going to determine the structure. And so the way these particular areas are made up, the types of tissues that are there, the types of features that are there in the tissues are very important. So we have nasal hair, the full-on hairs that can actually trap particles. Then we have mucus. The formation of mucus from those mucous membranes is sticky and gooey and gross, right? But it traps microorganisms very well. Once they're trapped, though, we have to get them out. And so the first part of that is going to be the cilia. So if you have ciliated epithelium or ciliated skin tissue, that cilia acts in what we call the ciliatory escalator to sweep that mucus and the microbes along with it out of the body, okay? Then we also have the involuntary responses like coughing and sneezing and swallowing that can help move them on out as well, okay? These are part of our first line of defense. Our second and third line of defense, of course, also assist. We can have complement activated, our antimicrobial peptides, increased levels of chemokines that help battle microbes and pathogens that are in the lung. We have macrophages in the alveoli and tonsils, and you will also find secretory IgA antibodies in the mucus. All right, so the normal microbiota for the respiratory tract, upper and lower, is pretty important. Be sure that you know this slide. We've got actually thousands of normal microbiota that are in a commensal relationship in our respiratory tract. However, for someone that is immune compromised, these can actually cause a serious disease. Sorry, I'm trying to get my desk situated here. And so the healthy upper respiratory system will have thousands of these microorganisms. Even the lungs can sometimes have a limited temporary normal microbiota. Normal biota that can cause a serious disease in somebody that's immunocompromised, or if we get a state where they are kind of out of bounds, are going to be Streptococcus pyogenes, Haemophilus influenza, Streptococcus pneumonia, Neisseria meningitidis, Staphylococcus aureus, Candida albicans also. Other fungi also can sometimes colonize your mucosal surfaces. So the composition of the lung microbiome can be different in somebody that has a chronic inflammatory condition such as COPD, asthma, cystic fibrosis. Smokers and non-smokers will have different microbiota as well. Part of that is smokers, their cilia do not work properly anymore, so they don't sweep things out. And so that composition will be a little bit different. So normal biota, remember, are going to be antagonistic, make the area unhospitable for other microbes. They take up space, so they take up housing, they take up food, and then sometimes they remember, produce certain things in their metabolism that are unfavorable towards other species, okay? And so they're going to reduce the chance of pathogens establishing themselves by competing, by competition for resources in space, okay? We also have some things like lactobacillus sacchi, that's one particular species, or Corynebacterium tuberculosum can actually be found in the sinuses as well. All right, starting with the diseases, here we have pharyngitis. What is pharyngitis? Well, it's an inflammation. Any itis is inflammation of, right? And of course, it's going to be of the pharynx. So this is inflammation of the throat, is what we would normally say. It's going to cause pain, swelling, reddened mucosa, swollen tonsils, white patches, and those white patches that we see are inflammatory products, okay? And that's so like something you particularly see with something like strep. Sore throats are caused that are caused by bacteria are going to be more painful than those that are caused by viruses, and they're also more likely to be fever causing, okay, and have some headache and nausea as well. You will have an incubation period of about 2 to 5 days. You can also have a sore throat due to mechanical irritation from prolonged shouting, drainage from the sinus cavity, which we probably all have. Okay, so the most serious cases of pharyngitis are going to be Streptococcus pyogenes and other members of group A strep. All right, so Streptococcus pyogenes is a gram-positive cocci. So strep means in chains. Cocci would be round, so you can see the gram stain of one of those here above. I try to throw some of those in for many of the bacterial species. It is non-motile, so it doesn't move around. It can form capsules and slime layers, all right? It's a facultative anaerobe and is able to ferment sugar, many different types of sugars, okay? Strep throat, can be really bad, but it's really important that you seek treatment for strep throat, okay? This is really important in today's age because, used to it was a problem because we didn't have antibiotics, and so children would develop things. You can get scarlet fever, scarlatina, or even rheumatic fever because of a strep infection if it's left unchecked, and that quit being quite a problem in at least industrialized world areas anyway, until we started having this movement of homeopathic products. And there's nothing wrong with those, they do work, they're just not quite as effective as medications that you can buy, like antibiotics. And so I know there have been some people that I know of that tried to treat their child that had strep throat with just essential oils or something, and it's really, really important that you don't do that, because this can also, if you have rheumatic fever, remember that can go and actually cause a problem in the heart as well, okay? So we don't want to let this go unchecked, and be wise when we're choosing products for our health care. Nothing wrong with trying something when symptoms are small, something herbal that can be very beneficial, but it's just not as strong as the man-made medications. And the antibiotics that we actually don't make man-made. Some of those are made by other things, okay? And so anyway, this can develop into scarlet fever, which is Streptococcus pyogenes can have also a bacteriophage that can produce what's called an erythrogenic toxin, and it causes this sandpaper-like rash with a very high fever, and can have a fatality rate up to 95%. So that is not something to play around with, okay? Rheumatic fever is actually due to a reaction between the M proteins on the streptococci and the heart muscle. Okay, and so that can cause damage to the heart valves as well. So untreated streptococcal pharyngitis can lead to scarlet fever. It can even lead to pertussis, rheumatic fever, glomerulonephritis, or erythrogenic rash. Okay, so definitely need to seek treatment here. The virulence of Streptococcus pyogenes is due to two things. One is the ability of those surface antigens to mimic the proteins of the host, and so we are not able to recognize it as non-self as easily. It basically kind of disguises itself as a protein that belongs there. And it also has some super antigens, okay? And these are some, there are some specialized polysaccharides that help protect the bacteria from being dissolved by lysosomes, okay? They have lipoteichoic acid, and that helps them adhere to the cell wall and the pharynx. They have that M protein that we discussed. They have hyaluronic acid, and they also have a capsule, okay? That capsule also can help it hide from the body and also with adhesiveness. Okay, so there is no vaccine for Streptococcus pyogenes, unfortunately. It does have some toxins, some extracellular toxins. They're streptolysins, okay, and these actually cause hemolysis of blood cells, all right? And this is going to be a beta hemolysis, and you'll see this on this blood agar, which is at right, and this can really injure cells and tissues. And then again, it has that erythrogenic toxin, and that gives us that bright red rash and causes a fever, okay? But only the ones that have the genes that they pick up from the bacteriophage can actually make that toxin. So not all of these organisms of Streptococcus pyogenes can do this. Okay, and so this is transmitted by droplet contact with mucus secretion, so like sneezing. It is normal biota for about 15% of the population. And there are 80 different serotypes, 80 different varieties of this. So this does make it difficult to identify and for our immune system to pick up, okay? Let's see. So prevention is going to be washing your hands, especially after coughing or sneezing, covering your sneeze. And before preparing foods or eating, you want to wash your hands. Penicillin is the antibiotic of choice. If you have penicillin allergies, they can prescribe cenfalexin. Most sore throats caused by strep pyogenes can actually resolve on their own. But if they do not, they need to be treated by antibiotics to prevent those serious complications or sequelae. All right. Let's see. I think we've covered everything here. All right, so the common cold. Why can't we cure the common cold? Well, the common cold is actually caused by over 200 different viruses, okay? Rhinovirus is the most common to cause rhinitis, which is another name for the common cold. Also, the coronavirus, adenovirus, and RSV, okay? So coronavirus, people think is new because we've had this big bout of coronavirus, so all of a sudden the name is in the news. And this is a novel strain, which means it's a mutated new strain of SARS-CoV or coronavirus 19. All right, the first one of those came about a few years ago. It was a little more virulent. This one is also more virulent as well, which means it's worse than normal. So it's worse than a normal cold. So it's kind of mutated to where it's a little worse than normal cold. Most normal colds, though, have a 2 to 5 day incubation period. Okay. Spread by indirect contact or droplet contact, not contact, okay? And we're pretty familiar with the symptoms here: sneezing, scratchy throat, runny nose, sometimes fever, especially with children. So infectious agents that can cause sinusitis commonly also include a variety of viruses or bacteria, and even sometimes fungi. So infections of the sinuses often follow a bout with the common cold. So inflammatory symptoms here can produce a large amount of fluid and mucus, and when that gets trapped in the sinuses, the secretions provide a really great area for growth for bacteria or fungi, okay? So viral rhinitis is often followed by sinusitis caused by a mixture of organisms, okay, or a sinus infection, okay? Treatment, if needed, will be broad spectrum antibiotics for the bacterial infection, for that secondary infection, and or antifungals. If the fungal infection is really bad, sometimes they even do surgery. This is where they would go in and scrape the sinuses. All right, so otitis media. This is the common, this is an acute ear infection, okay? So viral infection in the upper respiratory tract can cause the eustachian tube, okay? The eustachian tube, which is the ear canal, to become inflamed, and fluid then will build up in the middle ear, and that fluid then is a medium for bacteria to multiply. The ear does not have normal biota, but bacteria do travel along the eustachian tube. Children are especially prone to this. They can have chronic otitis media when fluid remains in the ear for long periods of time. The reason that they are more prone to this is that they are not fully grown, and their tubes, their eustachian tubes, are actually shorter than an adult. So this is why they grow out of them. And so that helps, not helps, but it causes that fluid to build up even more. Sometimes they also get a biofilm that builds up, which makes it even more difficult to treat with antibiotics. So the most common causes here are going to be Streptococcus pneumoniae, Haemophilus influenza, but that can be caused by other bacteria or viruses. We do have a vaccination for strep pneumoniae now. This is Prevnar, and it's antigenic and contains 13 different strains. And this is This is different than the vaccine for pneumonia, okay? Even though it's a similar organism, okay? We do have antibiotic resistance that occurs. So they have now taken the they've decided now the best thing to do is and this has been a while, actually, watchful waiting. So they like to wait a few days and see if it clears up on their own before antibiotics are used. They want the body to have time to fend it off before they use antibiotics, okay? And then if your child meets criteria and has so many numbers of ear infections before the age of 2 or at a certain age, they can place in tubes, and those tubes will actually go in the tympanic membrane, and that will allow that fluid to drain and keep it from building up, therefore preventing ear infections or otitis media. All right, so time for an NCLEX prep question here. What information should be included in health promotion classes for parents of school-age children regarding the treatment of sore throats? A, as long as the child does not have fever, there is no need to seek medical treatment. B, provide fluids as tolerated and keep the child well hydrated. C, parents should take their child to a healthcare provider so a rapid throat culture can be obtained. Or D, if the child can swallow with minimal pain, all is needed is increased fluid. Pause here. All right, well, the best answer is going to be C. Is it wrong to give more fluids? No, that's always a good idea when somebody's sick, but that is not the most important thing. The most important thing is you need to know if it is a strep infection. They need to do a culture and grow it out and see what the cause is, because you do not want that strep infection to go untreated. That will cause more serious disease, kidney inflammation, scarlatina, rheumatic fever, those things that we talked about. The next one is diphtheria, and you probably know the name, but you've probably never heard anybody having it, right? Well, that's because we have vaccinations for this. This is caused by Corynebacterium diphtheriae. This is a non-endospore-forming gram-positive bacterium, and it is kind of club-shaped, as you can see in this picture over here, okay? This little end here has been dyed so you can see it purple. All right, it's a little harder to see in these. You have to look really closely to tell that it's club shaped. Okay, so that's it. I like that picture. So this has a characteristic membrane that can actually form over the tonsil or the pharynx in a child. Okay, kind of this grayish brownish type membrane. This has this is spread droplet contact, a direct combat, or via fomites. This major virulence factor that it has is this exotoxin, which the bacteria, again, pick up from a bacteriophage through lysogeny. If they do not have this factor, then you won't get really sick with this. But if they do have this diphtheria exotoxin, it can cause complications in organs. It can cause myocarditis, neuritis. Neuritis is going to affect motor nerves and can cause paralysis, temporary paralysis. So this is not a good thing. Diphtheria toxoid vaccine is part of your normal childhood vaccines, DTaP, TDAP, Tdap, or TD, okay, which is going to be diphtheria, tetanus, and pertussis, all right? And so the last one doesn't have pertussis. So you can treat it with an antitoxin and an antibiotic, such as penicillin or erythromycin. We should not see this day and age because we have vaccines to it. For it, one of my fears, though, is we do have so much going on with anti-vaccination, this could come back. And if you have this virulence factor, this can cause a serious disease and death. So keeping those vaccinations is very important. All right, so next we've got influenza. We have influenza A, B, and C. This is from the family Orthomyxoviridae. All right. These, well, let's back up for a moment. We see cyclical increases of influenza every year during the winter months, right? There's kind of a flu season, and so we study these different strains and try to predict which strain is going to come out. Well, you've probably heard of some of these strains like H1N1. I think that was bird flu. The H and the N come from these spikes, these lipoprotein spikes here on the outside. We have one that is hemagglutinin, one that is neuraminidase, and that's where the H and the N come in. And so that's how we identify the different strains, because there will be differences in those particular proteins, okay? The evolution of influenza is very important to understand how viruses, one, can cause very serious disease, two, are able to get around our immune system by changing by what we call antigenic shift or drift. Okay, and we'll look at that I think in a few slides, maybe the next slide. So this can begin in the upper respiratory tract and then progress, of course, down to the lower respiratory tract. It can cause headache, chills, dry cough, body ache, stuffy nose, fever, sore throat, fatigue. You can also, of course, get those secondary infections, pneumonia sometimes. So the influenza viruses, they're kind of spherical. They're about 80 to 120 nanometers large. And they have those lipoprotein envelopes. We can see that here at right. These two glycoproteins, again, are what not only we identify, you can see here we've got the H and the N, but they are also what contribute to their virulence, okay? So it's not just for naming, but also they contribute to their virulence, okay? And they spread by droplet, direct or indirect contact. So antigenic drift or shift is where you have antigens, and that's these little proteins on the outside that gradually change the amino acid composition, or at least the genes that code for these gradually change. And they can kind of come together, and that's what this picture here is showing you. You've got a duck flu and a human flu. Those can kind of merge together. The pig maybe gets both. They kind of get put together, and then the human influenza virus can have the duck H spike. And so our body does not recognize them as well. We're not able to create memory cells to give us immunity for these, okay? Antigenic drift is the reason that a new vaccine is required for each year, okay? That's why it's a seasonal vaccine. We also have antigenic shift, and this is where RNA exchange occurs between different viruses. And so they're kind of the same, but kind of different, okay? They kind of occur hand in hand. You got to have one for the other to occur. And so they're constantly mutating these glycoproteins, these antigens on the outside, okay? I think that's about all on here. So basically you wind up with a hybrid influenza virus that makes it very hard for us to predict and for us to combat, because it's always changing. So the virus here is going to bind to ciliated cells in your respiratory mucosa. And then it's going to cause these cells to shed, okay, along with a lot of viruses on them as well. And so that's going to help to spread the disease. You can have a cytokine storm with influenza. You can also have this with COVID as well. And this is where your immune system ramps up inflammation so much that it's actually the inflammation that winds up killing the patient instead of the illness. So we see that with influenza, particularly the older generation, and we see that also, we've seen that with the coronavirus as well. So it causes that severe inflammation, okay? All right, and so we've seen really how effective cleaning and washing your hands and social spacing can be in preventing the flu when we did all of this for coronavirus, and we've noticed that the flu rate went down a lot this year, okay? So to diagnose this, you can use culture and non-culture based tests. You can do a PCR, a rapid PCR test. You can send a culture to a diagnostic lab and get a result back in 10 days, which is kind of late. There is, of course, vaccines, all types of influenza vaccines. We have trivalent, which means there's 3 different strains, quadrivalent, which is 4 different strains, and they're looking at there's research for a new vaccine that is actually going to be effective against any variant if they can get this done. Okay, it's not finished yet, but they're working on it where it will recognize all the different strains. Okay, so the CDC does recommend anybody of 6 months age or older gets one of these vaccines. Of course, a lot don't. I get mine almost every year. I'm exposed to lots of stuff being a teacher, and it's just better than being sick. Okay. And so let's see, you can target the ion channel proteins, and that can eliminate all strains. That wouldn't need to be given every year. I'm not sure if that's how the new one is going to be designed, if that's what they're looking at or not, but that's just a way that it could work. This has got to be taken, if you want to take medications, like Romantadine and Amantadine, you can. Those are going to be antivirals, and they can prevent type A, but not type B. There are some other types of inhaled medications, Relenza, that works against A and B, and then there's Tamiflu as well. We do have some resistance to those that we've seen starting about 2008, 2009. They don't work great. I know, for instance, Tamiflu myself makes me sicker than having the flu. I don't really know why, but there are people, of course, that have reactions to different types of vaccines based on some of the products in them. So anyway, we're making strides, but so far nothing great yet other than the vaccine. And even that, like we said, there's such a mutation rate. It's kind of a educated guess as to which one that is going to come out. Next, we have pertussis, which is whooping cough. All right, this has actually kind of been a re-emerging disease. Some of these have reemerged due to the anti-vaccination movement, which is very, very disturbing, because some of these diseases, like whooping cough, but some are much more virulent, like smallpox, which are very, very deadly. We do not want to see those reemerge. Some have reemerged due to mutations. Okay, and so they can just adjust the vaccines for that and fix that. So Bordetella pertussis is what causes whooping cough. This is part of the DTaP. The P stands for pertussis immunization. In the early stage, it seems like a cold. You've got a nasal discharge, you've got some sneezing, you're going to have droplet contact. You're going to have an incubation period of 3 to 21 days. You can get secondary infections, which can occur usually during the convalescent phase. This is a small gram-positive rod. You can see it's kind of a short, stubby rod there. What will usually happen is you will develop this uncontrollable cough, and that will be during the paroxysmal stage, okay? And it's severe coughing. I'm not talking about a small cough. I mean severe coughing to where you can't function. So that's during the paroxysm or proximal stage. And then you have the convalescent stage where you're starting to get better. So your numbers of bacteria are decreasing and you're no longer causing ongoing symptoms. So best treatment is prevention, which is going to be your DTaP vaccine. And then antibiotic treatment if you do come in contact. Most of the outbreaks today are due to lack of either getting the vaccination or lack of getting the boosters. Okay, treatment is erythromycin or a Z-Pak. Next, we've got RSV, respiratory syncytial virus. Okay, this is serious for infants 6 months old and younger. Okay, very highly contagious. We do see a peak of this in the winter and the early spring. It's transmitted via droplet contact and even fomite contamination. We do not have a vaccination that is effective against this just yet. Every year we see about 100,000 children hospitalized with this. You can treat it with ribavirin, but if it's very severe, you can use that. It can have a 3 to 5% mortality in premature infants, so it's highly, well, it's really bad for premature infants, okay? So under 6 months old, but premature especially, okay? And so it does form a syncytia, and this is where some of the cells actually merge together and act as one. All right, next is Mycobacterium tuberculosis, okay? This is going to show up with an acid-fast stain. It is a bacillus. It is a strict anaerobe, a strict aerobe, and it is very slow growing. And so myco, what do you think of when you hear myco? You think fungus. And so it somehow resembled a fungus, or they thought it was a fungus initially, but it is not a fungus, okay? It does have mycolic acids and waxes in the cell wall. It is somewhat resistant to drying and disinfectants. It does cause a very strong immune response, which does actually increase the pathology. You will see this Mycobacterium avium, instead of tuberculosis infection, actually occur in AIDS patients. This is actually a very ancient disease. It was called the captain of the men of death, or the white plague. And so this has been around for many, many, many years. It has re-emerged as a more serious threat. It affects about 2.5 billion people worldwide. 85% of tuberculosis cases are going to be contained in the lungs, but you can have it spread. Clinical tuberculosis forms, you can have a primary infection, a secondary or reactivation infection, and you can also have disseminated or extrapulmonary, so outside the lungs, okay? So bacilli can actually live dormant in the lungs and then be reactivated later in life. Symptoms of an active tuberculosis infection would include a low-grade fever, coughing, fatigue, weight loss, and night sweats, okay? It can, like I said, disseminate to other lungs. There is a vaccine. There's the BCG vaccine that is used primarily in other countries. All right, so let's look at each of these types. We've got primary tuberculosis, which is going to spread via vehicle or airborne, okay? This is considered a serious threat with the CDC for antibiotic resistance. The infectious dose is very low. It only takes about 10 bacterial cells for you to get sick, okay, or for you to catch it. Bacteria are going to multiply actually in the macrophage, and so the infection is going to be hidden from the immune system and asymptomatic for a while. You may have mild fever at that point. It can escape from the lungs and lymphatics, and that can lead to a cell-mediated attack. You'll have a large influx of mononuclear cells. You can have what's called a tubercle form in the lungs, which kind of acts to try to wall in or close in the granuloma. You get granulomas form, and your body tries to wall them in and stop the spread of infection, which it does. But then it carries the potential to cause damage, okay? Neutrophils release enzymes at the center of these tubercles, which are going to break down into a necrotic lesion, okay? And those are going to heal by calcification. So your normal lung tissue is going to be released by calcium, okay, forming the little granulomas of calcium in your lungs. And so your T cells are going to, during a tuberculin reaction, can be used as a diagnostic tool, and this is how we do the TB skin test. If you have an infection outside of the lungs, you can have regional lymph node swelling. You can have renal tuberculosis when it gets in your kidneys. It can affect your long bones, the genital tract. You can actually have genital tuberculosis. You can have tubercular meningitis. You will see this in patients that are immunosuppressed and sometimes young children. Complications here can often be fatal. So the top right here, you have a tubercle. You've got the granuloma here inside. It's kind of that purplish, let me turn my thing on here, this purplish part here. It's obliterated the alveoli in it. And then at the bottom right here, you've got the necrotic tissue. That's the white portions of the lung from a biopsy. So a secondary infection of tuberculosis is when it is reactivated. Live bacteria, like I said, can stay dormant and then reactivate weeks, months, or even years later. You can also have a chronic form of tuberculosis where tubercles are going to fill with masses of bacteria, expand and cause the cavities in the lungs to expand and drain into the bronchial tubes and the upper respiratory tract, and the patient will gradually experience more and more severe symptoms. This is what we used to call consumption before they really understood what it was. You'll see coughing with a greenish or bloody sputum, low-grade fever, weight loss, extreme fatigue, night sweats, chest pain even. And so an untreated secondary disease has a 60% mortality rate here. This will be transmitted by droplets of respiratory mucosa in the air. It can live for up to 8 months in fine aerosol particles, okay? You can be made more susceptible by things like inadequate nutrition, immune system not functioning properly, poor medical care, and lung damage. You will see people in areas like nursing homes, hospital, or jails at a higher risk, which is part of the reason you have to have your TB skin test. So diagnosis of this is going to be based on the Manteau test, which is our traditional TB skin test. You can do an interferon gamma assay on a blood sample. You can isolate it and culture it and do an antimicrobial susceptibility test, and also ACID-FAST is a supplement to all of these techniques as well. So here's that traditional TB skin test, which I'm sure many of you have had. Teachers have to have it as well, so I've had to have this when I started teaching. Like I said, Manteau test. This is a purified protein from tuberculin. It's going to be injected into the dermis, and it's going to form a small bleeb from the injected fluid, but that's going to be absorbed in a short period of time. 48 to 72 hours later, the skin reaction will be read or rated, okay, by the size of the raised area. If the area is 5 to 9 milliliters, then it is positive, or greater, it is positive, okay? If it is 10 to 14 millimeters, the person is positive and rated category 2. If it is 15 millimeters, the person is positive, the person is in category 3, and the surrounding red area here is not red, just the size of the raised area. So how do we treat tuberculosis, okay? Well, we can help to prevent it by limiting our exposure to infectious airborne particles. Isolation of patients in a negative pressure room when a person is diagnosed with active tuberculosis. We've got a live attenuated vaccine, although it's not used in the US. Vaccinated individuals will respond positively to a TB test, by the way. So we have resistant forms. MDR TB is resistant to some medications like rifampin. You are going to need to be treated within 18 to 24 months with 4 to 6 different medications if you obtain tuberculosis. Even with treatment, people with the MDR resistant form, about half of those people will die. So it's not a good thing. The resistance is a big problem. Although it does account for less than 10%, even 9% of the cases. All right. It has about a 70% mortality rate within months of diagnosis for the MDR resistant form. So pneumonia is a disease where you have inflammation of the lungs where fluid is going to fill up the alveoli. You have a lot of different microorganisms that can cause pneumonia. Pneumonia can be caused by things like Streptococcus pneumoniae, Mycoplasma pneumoniae, and Legionella. Those are some of the bacterial causative agents. We have Histoplasma capsulatum, Pneumocystis jirovecii, which are fungal causes. Histoplasma capsulatum, it grows in moist soil, especially soil that is rich in nitrogen from bird or bat droppings. these are going to have characteristics that allow them to penetrate and survive in the lower respiratory tract. Also, they can avoid phagocytosis or avoid being killed once inside the macrophage. More children die of pneumonia than of any other infectious disease, okay? 2 to 3 million cases in the U.S., about 45,000 of those per year die. So similar to MRSA, we have some community-acquired strains and some hospital-acquired strains. So Streptococcus pneumoniae is a community-acquired strain. That's going to be about 40% of community-acquired bacterial causes. This is going to be the most lethal form than any other microorganism, okay? Pneumonia can be a secondary effect of influenza, by the way. Streptococcus pneumoniae is sometimes called pneumococcus. It's a very small, gram-positive, kind of flattened cocci. So it looks, you can see over here to the left, if you get too close together, they're kind of flattened, so they almost look like a rod shape in a few spaces there. They're usually diplo, so they're in pairs lining up end to end, but not always. It does have a capsule, which contributes to its virulence. It's going to be more likely to affect someone that is older in age. You're more likely to get it, of course, in certain seasons of the year. If you have underlying respiratory disease, diabetes, if you have alcohol or narcotic abuse, you're more likely to get this. If you are 50 or older, there is a vaccine that is recommended, or somebody that is high risk. This can be alpha hemolytic on blood agar, so that is a test we can use. In healthy people, your host defenses will generally fend this off, okay? And it is spread, by the way, via droplet transmission. There is some antibiotic resistance here. Treatment is generally going to be with cefotaximine or ceftriaxone plus vancomycin, okay? So that's a combination there, sometimes plus vancomycin. Our next community-acquired pneumonia is Legionella pneumophila. Okay, this is less common, but still causes a serious disease. This is a gram-negative polymorphic. That means it can have many different shapes. Ranges from cocci all the way to filaments. There are many subtypes. This is going to be widely distributed in an aqueous type habitat. It's found in tap water, cooling towers, ponds, fresh waters. It's resistant to chlorine, and it can live in association with an amoebas. This can be released during aerosol formation and carried a very long distance. It can also travel by vehicle transmission, not a car, but vehicle, on water droplets, okay? Azithromycin is one of the treatments here. Hantavirus is another community-acquired pneumonia. This is in Pneumonia viridae. It is an enveloped virus. It can cause severe kidney disease and hemorrhagic fevers. In 1993, there was actually a cluster of cases of very severe lung edema among very healthy young adults in the Four Corners area. And this is where they discovered this new hantavirus pulmonary syndrome, and this can cause severe kidney disease and hemorrhagic fevers, okay? It's associated with the presence of mice being in close proximity with humans. It can be transmitted via airborne dust that has been contaminated with urine, feces, or saliva from infected rodents. It is zoonotic, of course. Other symptoms are going to be abrupt fever, lung edema, respiratory distress, hypotension. First outbreak actually occurred in 1993 in the southwest of the U.S. It has a reservoir for a deer mouse. The deer mouse is the reservoir. Treatment is going to be supportive and palliative care. So next we've got Histoplasma capsulatum. This is a fungi. This is going to infect many people but can cause a pneumonia-like disease in a few. It is found all over the world except for Australia, and it is found in the eastern and central U.S. to be at the highest rate. Okay, this again grows in moist soils that have a high nitrogen content. 80 to 90% of people have been exposed to this. It is undergoes vehicle transmission and inhalation of contaminated soil, able to survive phagocytosis. Treatment is going to be with amphotericin B. Some atypical causes of pneumonia can be community acquired, like Mycoplasma pneumoniae, chlamydia pneumoniae. These can cause the less severe form of pneumonia we call walking pneumonia. This is going to be transmitted via aerosol droplets among people living in close quarters, like the military, students, that type of thing. It's called walking pneumonia because usually people don't realize that they are sick. It just tends to hang on for a very long time. Pneumocystis gyrovecii, which used to be called pneumocystitis, carini, is an opportunistic pathogen, and it's the most frequent cause of life-threatening pneumonia in AIDS patients. Okay, it was obscure actually until they used it to help diagnose AIDS patients, which I believe we've already discussed. It was actually first discovered in 1909. It's likely transmitted through inhalation of spores, and traditional antifungal drugs are actually ineffective against pneumocystis pneumonia. The chemical makeup of the organism's cell wall is the reason why. Many healthy people actually have this as normal biota, and that's why they were able to use this to help understand AIDS, because they were seeing lots of lots of young men who would not normally be affected by this, okay? And they were showing up with this. And so this has kind of led them to dig deeper. It's spread via droplet transmission. Antifungals are often given to AIDS patients to prevent this. Treatment is trimethoprim or sulfamethoxazole. Many respiratory viruses can also cause a community-acquired pneumonia. And these will be residents of the upper respiratory tract that can be acquired through daily activities. These are generally going to be mild illnesses. These are spread via droplet contact. Healthcare-associated pneumonia can be a cause for about 1% of hospitalized or institutionalized people. It is often associated with things like mechanical ventilation, like a trach or tracheostomy. It is sometimes called ventilator-associated pneumonia. And this is going to be gram-negative or positive bacteria from the upper respiratory tract, sometimes even the stomach, or environmental contamination occurring on the ventilator. And it can be transmitted via aspiration. It's often polymicrobial, so it often involves several species. And so sputum and tracheal swabs here are not useful. It's better to get a culture from the endotracheal tube or doing bronchoalveolar lavage. Antibiotics is needed if the patient is already receiving them, but it can affect the results. Okay, you can see MRSA as being an issue here. Pseudomonas, Klebsiella pneumoniae, Enterobacter, E. coli, or Actinobacter, okay? And so the way to prevent this is going to be things like elevating the patient's head to a 30 to 45 degree angle to help reduce aspiration of secretion. Good preoperative education for patients about the importance of deep breathing. Frequent coughing can reduce postoperative infection rates. Proper care of those mechanical ventilators, respiratory therapy equipment, those types of things. Treatment is going to be broad spectrum antibiotics. This prevention is vitally important. Okay, mortality rate is 20 to 50%, or 30 to 50% actually. The table says 20 and the text says 30, so we're going to go with 30 to 50%. All right, so here's another NCLEX practice question. These are really important to practice, not just for the NCLEX, but they also help you to apply information. And I've noticed that these are missed a lot on your exam, and these are pretty much application questions. So if you really know your material, you should be able to answer these. A nurse is developing a health promotion class on which identification and prevention of tuberculosis. Which clients would the nurse like to include in TB testing? Select all that apply. A client who is HIV positive. B, a male age 38 who works as a prison guard. C, a nursing student with no comorbid conditions. D, a migrant farm worker with limited health access but has come to the clinic for information on diabetes. And E, a female age 26 who has been traveling abroad, visiting endemic areas. Okay, so this is going to be A, the client who is HIV positive for sure. You're going to also want to include B, the prison guard, because they are working in close conditions. C, you do not need to test. D, the migrant farm worker, you definitely need to test. And E, the female who has traveled outside of the country also needs to be tested as well. I don't include these in all of these PowerPoints, but I thought I would include it here and point them out. These are color-coded. I may have done this in another one. Bacteria, viruses, and fungi, and putting this out into a visual form. You will find that doing things visually is actually very, very helpful. It's much easier to remember a visual picture of something than it is the words, although this does include words. And then the color coding, green for viruses, for instance, is also very, very helpful. So I would recommend doing this on your own. Go through your textbook, make you a very rudimentary, it doesn't have to be fancy, diagram here of the body and the system that is affected, and go through your chart and do this yourself. And then at the end of the chapter, go back and find these and double check that chart with this to make sure you've included everything and labeled everything correctly. Just by doing that is going to help you reduce the time of studying you need to do, because you'll know this material better. Now you can just sit here and copy it and try to memorize it, but it's really better if you just try to make it yourself, because that's, like I said, it may seem like more work up front, but honestly, you're going to learn it better, and you're not going to have to spend as much time studying. Okay, so pay attention to these.